Hello everybody. Today we are going to discuss about ascites. So first we will start with definition. Ascites is basically the accumulation of the fluid within peritoneal cavity. Now we'll see what are the causes of ascites. So around 84% of the cases of ascites is because of cirrhosis. Then the rest 10 to 15% is because of cardiac ascites, peritoneal carcinomatosis, and the mixed ascites which are resulting from cirrhosis and secondary disease. Then there are some less common cause of ascites which include massive hepatic metastasis, infections like tuberculosis, chlamydia, pancreatitis, renal disease like nephrotic syndrome, and rare cause of ascites include hypothyroidism and familial Mediterranean fever. Now we will see why this ascites is happening or what is the pathophysiology behind it. So as I mentioned before, around 84% of cases of ascites, the reason is cirrhosis. Now, what exactly is happening in cirrhosis that it leads to ascites? So, cirrhosis leads to portal hypertension. Now, because of this portal hypertension, there is reflexly splanchnic vasodilatation. Now, because since there is vasodilatation, there is increase in the splanchnic pressure which causes lymph formation and that leads to ascites. Now, the another result of this splanchnic vasodilatation is also arterial underfilling. So, because of the arterial underfilling, there is activation of renin-angiotensin mechanism, that is RAS system, and sympathetic response is activated. So, because of this, it leads to the sodium retention, which causes plasma volume expansion that leads to ascites. Now about the clinical feature. So patient typically note increase in abdominal girth that is often accompanied by peripheral edema. So this development of ascites is often insidious and it is surprising that some patient wait so long and become so distended before seeking medical attention. Because if the ascites is mild, then the patient is usually neglecting it. Whenever there is a distended when patient is seeking help because this distension of the abdomen is causing symptoms like respiratory distress. So before the patient usually have at least 1 to 2 liter of the fluid in the abdomen before they are aware that there is an increase. So as I mentioned before, the reason for seeking medical help is respiratory distress. Now, why it is causing respiratory distress? Because the ascitic fluid is massive. Because of that, respiratory function is compromised. Another reason is that, as I mentioned before, the cirrhosis is the major contributor of ascites. Because of cirrhosis, there is sometimes hepatic hydrothorax, which again cause respiratory distress. So the patient with massive ascites are often malnourished and they often have muscle wasting and excessive fatigue and weakness. Now we will see what are the grades of ascites. So the grade 1 is mild ascites, which is only detected by ultrasound examination. Now the grade 2 is moderate ascites. It is manifested by moderate symmetrical distension of the abdomen. Grade 3 is the large or gross ascites, which provokes marked abdominal distension. Now about the diagnosis. Diagnosis of ascites is by the physical examination and it is often aided by abdominal imaging. So the patient will have bulging flanks and that may have a fluid wave or presence of the shifting dullness, which is determined by taking patient from supine position to lying down or either left to right side and noting the movement of the dullness or percussion. So subtle amount of ascites can be detected by ultrasound and CT scan. So if you want to diagnose ascites, then there are two methods. One is physical examination and the other one is abdominal imaging. So physical examination, there are certain tests by which we can evaluate ascites, like there is Puddle sign, shifting dullness, horseshoe dullness, and in the abdominal imaging, we can go for ultrasound and CT scan. So hepatic hydrothorax is more common on the right side, which implicates rent in the diaphragm with the free flow of ascites into thoracic cavity. So patient presents with the ascites for the first time, then it is very important to know what is the cause of ascites. If we don't know the cause, then the ascites will keep on happening. So how to determine this cause? So for that we need to send some investigations like total protein, albumin, blood cell count, differential and culture. Sometimes we can test another investigation like amylase, and if we are suspecting malignancy, then cytology. So it's very important to know the etiology of the ascites. For that, paracentesis is the option. Now there is a location for to perform this paracentesis, which is left lower quadrant. Now why this location is preferred? Because of the greater depth of the ascites and the thinner abdominal wall. And this remember, this procedure is associated with the least complications. So even if our patient has deranged coagulopathy, then also we can perform paracentesis. But please remember, if the patient is in DIC, then don't go for the paracentesis. And in that case, we actually have to compare the the risk-benefit ratio, and then we need to take the decision of going for the paracentesis. But yeah, this procedure is associated with the least complication of the infection, coagulopathy, so it is comparatively safer procedure. And even if the patient has the coagulation abnormality, we can go with this. Now, as soon as we perform the paracentesis, the first diagnostic clue from which we can actually guess the etiology is by the gross appearance of the ascitic fluid. If it is turbid, then the etiology could be infectious or could be malignant. If it is milky white, that means the cholesterol level is more than 200 mg, which is a hallmark of the chylous ascites. It could be result from the trauma, cirrhosis, tumor, and tuberculosis. If it is a dark brown, then the etiology is biliary tract perforation. If it is a black, then etiology is pancreatic necrosis and metastatic melanoma. The other investigation that we can send is measurement of albumin, total protein, cell and differential count. If infection is suspected, then the gram stain culture with inoculation of the blood culture bottle at patient's bedside to maximize the fluid and the cytology. Now about the diagnosis of tuberculous ascites. Now why it is important to diagnose tuberculous ascites? As we all know, the prevalence of the tuberculosis in India is higher. So tuberculous peritonitis is typically associated with ascitic fluid lymphocytosis, but it can be difficult to diagnose by paracentesis. So a smear for acid-fast bacilli has the diagnostic sensitivity of only 0 to 3%, but culture increases sensitivity to 35 to 50%. So in patient without ascites, and elevated ascitic adenosine deaminase level has a sensitivity of more than 90% for tuberculous ascites when the cutoff value of 30 to 45 is used. When the cause of ascites remains unclear, then we have to go for other option like laparotomy, laparoscopy with peritoneal biopsies for histology, and culture remains the gold standard. Now about the malignant ascites. Ascitic cholesterol determination followed by cytology and carcinoembryonic antigen determination in sample where cholesterol concentration exceeds 45 mg. It is appeared to be the cost-effective method for differential diagnosis between malignancy and non-malignant ascites. That means if we have done the diagnostic paracentesis of ascites, and if we have found the cholesterol concentration is more, and then it is a clue for means yeah, of course we have taken the history, we have physically examined the patient, and now in diagnostic paracentesis we have found that cholesterol level is high. Then we can go for the markers like cytology and the CA, so it can save the cost of the patient. And Yeah, it will help the patient overall. So, how to diagnose the spontaneous bacterial peritonitis? So, in our this ascitic fluid, if the neutrophil count is more than 250 and if the protein concentration is less than 1.5, then that is again then that is again pointing towards spontaneous bacterial peritonitis. Now, the another way by which we can diagnose the etiology of ascites is serum ascitic albumin gradient. So it reflects the pressure within the hepatic sinusoids and it correlates with the hepatic venous pressure gradient. So SAG is calculated. Now, how to calculate this SAG? So it is calculated by subtracting ascitic albumin concentration from serum albumin level, and let's see how this value helps in diagnosing ascites. So what we did is, first we have calculated serum serum protein concentration, and then we subtract it from the ascitic protein concentration, and if this value is more than 1.1, then the reason could be portal hypertension, liver related, or it could be because of the cardiac, or the reason might be the cardiac ascites. But if it is less than 1.1, then we need to think about the etiologies like biliary leak, nephrotic syndrome, pancreatitis, peritoneal carcinomatosis, and tuberculosis. But yeah, as I say before, if this value is more than 1.1, the reason could be liver, could be heart. So how to differentiate it further? So for that, we need to see ascitic protein. If it is less than 2.5, that means, uh, okay, if it is less than 2.5, that means the cause is, that means the portal venous, there is a damage in the this portal venous tract, and the cause is straightforwardly liver. So it could be cirrhosis, it could be late Budd-Chiari syndrome, or it could be massive liver metastasis. But if the ascitic protein is more than 2.5, that means the liver tract is intact and the cause is outside the liver. So it could be heart failure, could be constructive pericarditis, could be early Budd-Chiari syndrome, could be IVC obstruction or sinusoidal obstruction syndrome. So another clue from which we can actually differentiate whether the cause is liver or heart, and the one investigation which can help in this is pro-BNP level. If the etiology is because of the heart, then this pro-BNP level is elevated. Otherwise, it will be normal. Now, we have seen what is ascites, what is etiology of ascites, how to diagnose ascites. Now, how to treat ascites. Now, if the patient is presenting to us with a grade 1 ascites, then there is usually no need to treat it, and the patient is also not seeking for the treatment. But if the patient is having grade 2 ascites, then we need to start with medicines like spironolactone and furosemide. Now, why we are starting spironolactone? So, spironolactone is aldosterone antagonist, which will prevent the sodium retention, and the furosemide is diuretic, which will cause the fluid extraction. Now, how to start? Now, what is the dose of spironolactone? So, we can start with the dose of 100 mg, and furosemide we can start with the dose of 40 mg. And depending upon the patient response, we can escalate this dose. So, maximum dose of the spironolactone is 400 mg, and the maximum dose of the furosemide is 160 mg. So, but we have to be careful when we are prescribing these medicines to the patient. So, we have to see the side effects like electrolyte disturbances. So, as we all know, this spironolactone can cause hyperkalemia, and the Lasix can cause hypokalemia and as well as hyponatremia. So, also we need to tell the patient that they have to take the low sodium diet. And if the ascites is grade 3, then we can explore the other option like large volume paracentesis and TIPS. So please remember, if we are going for the large volume paracentesis, and if we have removed more than 5 liters of the fluid, we have to replace it with the 25% of the albumin. So, and the other option is tips. In tips, what we are doing, we are connecting portal venous system to the hepatic vein. So, but we have to be careful with the tips, because the tips has this deadly side effect, which is hepatic encephalopathy. So the final, if the patient is not responding to this treatment also, then the last option is liver transplantation. So the patient with cirrhosis and ascites, they are already on the increased risk of the renal failure. So we have to be very careful while prescribing certain medications like NSAID, aminoglycoside, and AC. If we are prescribing AC inhibitor and ARBs, then still we need to be very careful, because this patient, yeah, again, the patient can develop this renal failure. So we need to constantly monitor the creatinine and the renal function. So if I want to summarize, then if the patient is highly symptomatic, and then we need to go for the large volume paracentesis, fluid, albumin. We can prescribe diuretic. We can go for dietary sodium restriction. If the ascites is still reaccumulating, then the other options are like tips, uh, large volume paracentesis, albumin. Yeah, that is one of the option, and the last option is liver transplantation. Thank you, guys.